Good afternoon, dear students. Today we have our lecture, Modeling in Biology and Medicine. Today we will discuss next questions, general background on models, types of models commonly used in healthcare technology assessment, methods for selecting modeling methods. Before we start, we need to understand what is modeling. Modeling is the process of producing a model. What is a model? A model is a hypothetical description of a system of interest. The purpose of a model is to enable the analyst to predict the effect of changes to the different types of system. At this slide, you can see modeling process picture. We have a real-world fact or real-world data. By using simplification method, we created model. Then we analyze this model and make our conclusions about the real-world object. If we interpret this conclusion, we get real-world explanations for prediction, and then if we verify these explanations, we can understand real-world objects. Why do we use model instead the real object, instead the real system? Why not experiment with the actual system? There are two main reasons. If it is possible to experiment with the actual system, let's do it. But as usual, it is very difficult and it is very complicated. However, especially in healthcare, it is frequently too expensive, too disruptive, too slow, and unethical to experiment with the actual systems. Why are the models useful? At this slide, you see some explanations. Because models provide the means of testing our knowledge about the natural phenomena, provide the way to access computers to solve the problems, can safety test hypotheses. As usual, we use hypothesis in the assessment of the treatment or drug treatment. By using models, we can predict system behavior under untested or unstable conditions. For example, we have our next experiment. How many life years would be saved if every other person with age greater than 65 years had a one-time colonoscopy with polypectomy and surveillance every 3 to 5 years for positive findings? In the next point, you have explanation why it is expensive. Because we need to multiply each person, multiply by the cost of the colonoscopy, and add up follow-up costs. Disruptive, a day of inconvenience per patient for preparation and examinations, also disruption to gastroenterologists. Is there enough capacity in our healthcare area? Then it is slow, many years to get results, and possible it is unethical through uncommon perforations occur with unknown benefit to patient. There are different types of models which are used in medicine. Biological models or model organisms, physical models, and mathematical or computational models. Model organisms generally possess three main characteristics. They have rapid growth, short generation time, minimal creation and maintenance costs, ease of manipulation. As usual, we use model organisms in investigation in medicine and biology. At this slide, you see different examples. You see different examples of this biological models. Drosophila, Synopsis leaves, Mus musculus as the common, as the most often used creature. And Caenorhabditis elegans. What is the main differences between mathematical and physical models? Most people think of models, they envision physical models. For example, clay cars in wind tunnels or life-size layouts of an emergency room for a workflow analysis. The types of models used to evaluate the effectiveness and cost effectiveness of healthcare technologies are mathematical models. Mathematical models represent a system in terms of logical and quantitative relationships that are manipulated to examine how the model reacts and thus how the system would react if the model is valid. We can discern mathematical models into next classes. Deterministic mathematical models. This type of models is for a model, the input and output variables are fixed values. Stochastic, at least one of the input or output variables is probabilistic. Static, don't confuse with statistics. Static, time is not taken into account. And dynamic model, this is model, their time-varying interactions among variables are taken into account. Modeling process consists of some steps. First, we need to ask the question. Then we need to select the modeling approach. Next step is to formulate the model. Then we need to solve the model and verify if it is possible. And last step, we need to interpret the model. At this slide, you see an example of simple mathematical model. As usual, for mathematical models, we use a set of equations or mathematical formulas to describe the real process or real object. At this slide, for example, we get simple mathematical model for travel distance, which we can depict distance travels by using mathematical equation d, distance traveled, equals to rate of travel multiplied by time spent traveling. In this simple model, it is possible to get an exact analytical solution. This equation may apply to a single car on a test track, but it is little used to determining distance traveled on a busy highway with varying speeds and levels of congestion. In this simple equation, d equals r multiplied by t model, it is possible to get an exact analytical solution. Some analytical solutions can become extraordinarily complex. For example, inverting a non-sparse matrix and require substantial computing power. If an analytical solution to a mathematical model is available and computationally efficient, study the model in this manner. However, many systems are highly complex, so that valid mathematical models of them are themselves complex, precluding the possibility of an analytical solution. Such models must be analyzed by simulation. That means numerically varying the relevant model inputs to determine how they affect the output measures of interest. Evidence from randomized controlled trials remain the highest quality data source for evaluating the efficacy of healthcare interventions. However, evidence from randomized controlled trials alone can be uninformative if the randomized controlled trials endpoints are not translated into measures that are evaluated by patients, providers, insurers, and policy makers. For example, in patients with osteoporosis, fracture risk evolves over a lifetime from the development of peak bone mass to subsequent bone loss and the age-related increase in the likelihood of falling, among other factors. It may take decades to determine the effects of osteoporosis interventions. Hence, the most informative osteoporosis interventions, randomized controlled trials, would potentially last for some decades. A similar situation exists for many other chronic diseases such as diabetes, colorectal and prostate cancer, and Alzheimer's diseases, and other diseases also. The lengthy clinical trials needed to properly evaluate interventions for these chronic diseases would require financial and time opportunity, costs that would make them infeasible. Very few epidemiological studies of clinical trials are able to measure disease progression and the impact of interventions on costs, quality of life, and health outcomes over a lifetime. In the absence of such information, the most practical method to evaluate the health outcomes and costs of interventions is to develop models that integrate relevant data and extrapolate to long-term time horizons. Models that evaluate healthcare interventions synthesize evidence on health consequences and costs from many different sources, including data from clinical trials, observational studies, insurance claim databases, case registers, public health statistics, and preference surveys. Even then, the disease does not require a long-term evaluation period. Models can prove valuable by using results from indirect comparisons of individual randomized controlled trials to compare treatments not studied head-to-head and estimate outcomes not consistently measured, allowing the extrapolation of effects to populations not studied in a particular randomized controlled trials, allowing sensitivity analysis of assumption addressing treatment efficacy, health state utilities, cost, and so on. Decision model is a structured representation of a decision process that allows a person to perform a decision analysis. Decision analysis is just a systematic articulation of common sense. Any decent doctor, or let's call she or he decision maker, reflects on alternatives, is aware of uncertainties, modifies judgment on the basis of accumulated evidence, balances risk of various kinds, considers the potential consequences of his or her diagnosis and treatments, and synthesize all of this in making a reasoned decision that he or she decreases right for the patient. All the decision analysis is asking to the doctor to do this a lot more systematically and in such a way that others can see what is going on and can contribute to the decision process. At this slide, all types of modeling methods we can divide into different subcategories. Types of modeling methods frequently used in health technology assessment. There are three types: decision trees, Markov models, and microsimulation models. There are subcategories for Markov models, such as cohort and Monte Carlo methods. Microsimulation is divided into three parts: fixed time advance, discrete event, time to event without and with queuing for resources, and agent-based modeling methods. A decision tree. A decision tree is a diagrammatic representation of the possible outcomes and events used in decision analysis. The questions to be asked in analysis of the question are arranged as a series of decision or chance nodes, each node with resulting branches creating a tree effect. The sequential steps proceed with each step depending on the decision or probability outcome from the preceding step. At this slide, you see example of decision tree. Consider a patient who has a prosthetic heart valve and is receiving anticoagulant therapy. Such a patient may have an embolic or hemorrhagic event at any time. Each kind of event causes morbidity, short-term or chronic, and may result in the patient's death. The decision tree fragment in this figure shows one way of representing the prognosis for such a patient. The first chance node, labeled anticoag, has three branches labeled bleed, embolus, and no event. Both bleed and embolus may be either fatal or not fatal. If no event occurs, the patient remains well. Simple tree decision tree embody the essential paradigm of decision analysis. Especially, all decisions may be composed into three broadly defined components. Decision node. This is point in time when a choice is made among competing strategies. Decision strategy, set of actions or events consequent to a decision. Outcome nodes, this is terminal branches of three that represent outcomes or a strategy. Multiple outcomes, payoffs may be assigned. The expected value of a decision tree is calculated by averaging out or folding back the branches of the tree. The value of each strategy is path probability to the terminal node multiplied by the payoffs at the terminal node. Branching probabilities can be deterministic, represented by point values, or stochastic, represented by probability distributions. Uncertainty around branching probabilities and terminal node values is examined with sensitivity analysis. There are some advantages of using decision trees. First of all, it is graphical, so can diagrammatically represent decision alternatives, change chance events, and possible outcomes. Visual approach assists with comprehending decision sequences and dependencies. Decision trees are efficient, can quickly express common alternatives clearly, and easily modify as new information becomes available. Complementary, can use in conjunction with other methodologies, for example, apparent recursive methods to terminal nodes. But if we have advantages, we have some disadvantages of using of decision trees. The first disadvantage for decision tree is it must assume population being examined can be modeled in the aggregate. It being applied to an individual, assumption is made that aggregate probabilities are relevant to the individual. Does not specify then events occur. Assumes that each event can occur only once. can address previous two disadvantages with a recursive tree. At this slide, you see a recursive decision tree. Recursive tree modeling complications of coagulant, anticoagulant therapy. We have some previous terminal nodes of post-bleed, post-embolus, and no event are replaced by the chance node anticoagulant, which appears at the root of the tree. In a recursive tree, some nodes have branches that have appeared previously in the tree. Each repetition of the tree structure represents a convenient length of time, and any event may be considered repeatedly. Note that with only 2 time periods, there are 70 terminal nodes. 5 periods would have hundreds of branches. So if we use a recursive decision tree, this model is very complicated. Next type of model which is used to estimate effectiveness of the treatment is the Markov models. The Markov models provides a far more convenient way of modeling prognosis for clinical problems with ongoing risk. Describes as partially cyclic directed graphs, particularly useful when decision problem involves exposure to risk or event over time, ongoing exposures or situations where the specific timing of an event is regarded as important or uncertain, or they describing the timing of event is necessary for phase validity. Markov models assumes that a patient is always in one of a finite number of health states called Markov states. All events of interest are modeled as transitions. Each state is assigned a utility and possibly a cost, and the contribution of this utility depends on the length of time in the state. At this slide, you see Markov state diagrams. There are 3 states for the patient: well state, disabled state, and dead state. Common representation of a simple Markov process called the state transition diagram. We have 3 different states, and we have lines as transitions from one state to another state. Each state represented by a circle. Arrows connecting different states indicate possible transitions. States with arrows to itself indicate that patients may remain in that state in consecutive cycles. So look at the well state. Patient can remain the well state some cycles, and the same for disabled cycle. Note that transition from disabled to well nor dead to any other state are impossible. Time horizon in the analysis divided into equal increments of time called Markov cycles. Assume that a patient can only make a single state transition during one cycle. Length of cycle chosen to represent a clinically meaningful time interval. If time horizon is a patient's lifetime, then cycle is usually 1 year. If events occur more frequently, cycle can be a month or even a week in the Markov models. Evaluation of a Markov process yields the average amount of time spent in each state. Patient is given credit for time spent in each state in life years. Optionally, each state can be associated with a numerical factor representing the quality of life in that state relative to perfect health. For example, well equals to 1, disabled equals to 0.7, dead equals to 0. Utility associated with spending one cycle in a particular state is referred to as incremental utility. Analogous to utilities assigned to particular states, a cost may be specified for each state representing their financial cost of residing in that state for one cycle. Markov processes are categorized by whether or not state transition probabilities are constant over time. For example, transition probability from well to dead may consist of two components: probability of dying unrelated to disease in question changes over time as patient gets older, and the second, probability from disease. Part of hemorrhage of or embolus during cycle may or may not be constant over time. For a Markov model of n states, there will be n power 2 transition probabilities. Then these probabilities are constant with respect to time. It is called as Markov chains. They can be represented by n matrix. And in this slide, you see this matrix with different values for with all the possible probabilities. Most Markov models used in healthcare are semi-Markov. Unlike Markov chains, in semi-Markov models, state transitions may be allowed to vary or be time variant and usually need to be solved numerically via simulation. In Markov process, the behavior of the process subsequent to any cycle depends only on its description in that cycle. The process has no memory or earlier cycles. Because of this assumption, the prognosis of a patient cannot depend on events prior to arriving in that state. For example, patient is well after recovering from an osteoporotic forearm fracture. Through well, the probability of future fracture is likely higher than for patients in well without history of fracture. Build additional states to accurately represent these patients. At this slide, you see a Markov model and decision tree combination. If we are trying to choose between surgery and medical therapy, we may construct a decision tree like that shown in top figure. In this case, events of interest such as operative death and cure are modeled by tree structure outside the Markov process. A far more efficient structure is shown in bottom figure. In this case, the Markov process incorporates all events of interest, and the decision analysis is reduced simply to comparing the values of two Markov processes. At this slide, you see example of Markov cohort simulation. In the table above, we have some columns, and column 5 concludes sum of number of patients in each state is multiplied by the incremental utility of this state. First row does not contribute to sums. Patients will spend on average 1.5 cycles in the well state and 1.25 in the disabled state, for a net unadjusted life expectancy of 2.75 cycles. Markov cohort simulation are shown at this picture at the left. In the top level, you see all the patients are healthy, all the patients are well. Panel A top shows the initial distribution with all patients in the well state. Panel B, the middle level, shows the distribution pathway through the simulation. So some of the patients, all the patients are divided into three different groups. Some of them state well, some of them sick intermediate, and some of the initial group were dead. And at the panel C, the bottom line, the bottom level shows the final distribution with the entire cohort of the dead state. At the final state, all the patients are dead. At this figure, you see Monte Carlo simulation, and it shows the state transitions of a single person until death occurs during some cycles. At this slide, you see 6 cycles. The first state of the patient is well, the last state of the patient is dead. As an alternative to cohort simulation, analysis performed by individually simulations large numbers of individual patients. At the end of each cycle, a random number generator is used together with transition probabilities to determine on which state the patient will transition. Outputs from a large number of individual patients with constitute a distribution of survival values, the mean of which should be similar to expected utility of cohort simulation. Variance measures can also be determined from Monte Carlo simulation. Primary advantage over decision trees is the increased phase validity by capturing expected time horizons via Markov cycles. Disadvantages of Markov models. State transitions can only occur at the start, middle, or end, whichever is determined, or a cycle, creating potential biases. Cycle time may force simplifying assumptions regarding transition probabilities. Next method of modeling is the microsimulation. In microsimulations, patients are simulated as individuals as opposite to homogeneous cohort and represented by software objects called entities. One of the primary advantages of microsimulations is that the patient entities can be assigned attributes, and the occurrence and timing of patient events can be determined from these attributes. Microsimulations have the ability to ascribe a potentially vast number of contributions of characteristics to individually simulated patients. An individual's health state is defined by its combination of characteristics, not by its assignment among limited predefined health states, as in Markov cohort simulation. Eliminates the need for excessive number or defined health states, as patients' transitions to subsequent health states are dependent upon patient characteristics, not just their current health state. Types of microsimulations. There are a lot of different types of microsimulations. Some of them are shown at this slide. Fixed time advance. Patients can only transition to different health states, and fixed time intervals are defined by the circle length. Next time of microsimulation is the time to event. The occurrence and timing of an event is described, determined by a random sampling of a probability distribution. Discrete event simulation. Entities of patients may interact or compete with each other for system resources such as physicians, hospital beds, and so on. Key elements of discrete event simulation are entities, attributes, resources, and queries. Then a resource is not available for an entity. The entity is relegated to a query until a resource is available. Agent-based simulation. Independent multi-agent discrete event simulation. Agent entities contain information about their state and decision rules on how to communicate and interact with other agents. To choose most appropriate modeling method, we need to evaluate next criteria shown at this slide. First of all, we need to understand project type. Then we need to set up population resolution. We need to understand dependence or interdependence and feedback, treatment of time, treatment of space, resource constraints, autonomy or freedom of action of entities and populations, embedding of knowledge, and availability of evidential data. Project type. What does it mean, project type? Model, first of all, we need to understand which model to be used to answer a single question. There are different possible models. Models shown should only be complex enough to answer the single question. Model to be used programmatically or long-term. Methods that can handle more complexity usually required. Population resolution. do we need to use this model in aggregate? More simulation methods can handle. If we need individual level, micro simulation required. Interdependencies and feedback. Are entity interdependencies important? An infection epidemic involving exposure, unexposure, infected groups. Discrete event simulation or agent-based simulations required. Treatment of time. If time treated cumulatively or instantaneously, then trees can be used. If changes over time are important, time of therapy, surveillance interval, then Markov or microsimulations needed. Treatment of space. Is location important to the study question? Optimal distribution of mental health professionals in a state, then microsimulations or agent-based simulations needed. Resource constraints. If it is important to model limited sources and waiting lists, then discrete event simulation or agent-based simulations required. Anatomy freedom of action of entities and populations. Are all potential paths through the model predefined? Are absorbing states required? Are multiple paths open to the populations being modeled? Then discrete event simulation or agent-based simulation should be used. Embedding of knowledge treatment of space. Is the knowledge embedded in the structure of the model? So decision trees and Markov model should be used. Or is the knowledge embedded in the entities? This means we should use microsimulations. At this slide, we combined all the possible levels, how to choose appropriate model for a process or for object we need. All the questions are included into different levels. And at this slide, you see algorithm for choosing a simulation method. Is this used for single purpose or programmatic? Then we need to estimate population level. Is it aggregate or individual? Then interactivity. Is it important or not important? Then treatment of time. We need to consider treatment of time. We need to consider treatment of space if it is important. Resource constraints if it is important also. Agent autonomy. And the bottom level is the result of the different methods of simulation. So according to the answers, we can choose appropriate simulation method. We finish the first part of this lecture about modeling in biology and medicine, and we'll have practical tasks in this topic some later. Thank you for attention.